Assalamu alaikum. Welcome everybody on board. We will just start shortly. We have almost done all the important topics which are important for to prepare pediatric anesthesia. Okay. Some of the uh, things which we have discussed already. Anyone wants to ask if anyone has attended or has got any question related to pediatric anesthesia, you are welcome. Yes, Arsalan, do you want to ask any question related to pediatric anesthesia? Would you like to ask something before we start?
No, sir, you can continue.
Please continue.
Okay. Azhar, what I want to discuss today is some of the things related to pediatric anesthesia which we have not discussed. If we have covered almost all the important things. One of the topic I was just looking at it, and I think we have. What is cerebral palsy? Anyone wants to comment? Because if you are dealing with the pediatric anesthesia, some of the patients will be having congenital anomalies or birth defects, or for example any neuromuscular problems, and they are coming for some reconstructive orthopedic procedures, or they have some for contracture release, or because cerebral palsy has a lot of variation. Like it is usually because of any anoxia or any damage to neurological system of developing a brain. Okay. Or at the time of birth, if there is a hypoxic injury, so the result will be in any sort of impairment in the baby. Okay, which may be in the form of any spastic lesion or weakness. Okay, so cerebral palsy is a group of disease, and it has variable picture. It may be because of any, like if mother has some risk factor, and growth was retarded, and then any infection, like any infection like rubella, cytomegalovirus, it can result in this condition. Okay. So there cerebral palsy may be like spastic or mixed. Okay. Or there may be weakness. Okay. The patient may have ataxic movements, like tremors, or patient may have fits. Okay. And they are presented for a variety of surgeries. Okay. Have anyone of you not? Yes, Arsalan, what would you like to ask?
Sir, just add something, the definition of cerebral palsy. It is a central nervous system atrophy due to any lesion or infection which lead to motion and posture disability in a children.
Yes, you said atrophy. Atrophy is something else. Am I right?
Yes, sir.
Atrophy is because usually it is because of some like any cause will be cause, whatever is the cause, the result will be hypoxic injury. Okay. Usually it is the
Yes, sir.
it's like that. Okay. So usually these patients will be presented with some procedures like corrective surgery, or they will have some complication, like they will have gastroesophageal reflux problem. Okay. They will have pneumonias. Okay. They have problem in their normal food intake. Okay. So they are presented for this one gastrostomy tubes. Okay. Feeding jejunostomy. Okay. So your targets will be related to challenges will be related to the complications, or the procedure with the patient is like they will be muscle spasm, and they will have pain. If there will be it will be depending, as I told you, that there is a variety of thing. And atrophy, I'm not sure if you have read somewhere. I cannot um, because you see, this is a sort of the topic which we most of us don't read. Okay. So that's why I thought even I missed it during our initial discussions of pediatric anesthesia. So I just wanted to have few words about it, because they will have any procedures related to they will have a variety of picture, ranging from any spastic lesions to epilepsy to there is a problem which is a hyperactive disorder. Have you heard of it? ADHD, attention deficit hyperactive disorder. Okay. So there will be developmental delays. There will be milestone will not be achieved in time. Okay. So usually there is one condition which is related to cerebral palsy. It's a complication of anesthesia. Can you recall, Azhar, what anesthesia complication is related to cerebral palsy?
So you're asking for anesthetic concerns during, or what is the result of the complication? Kindly clarify, please.
Yeah. We have not discussed up till now. Like it is one of them is gastroesophageal reflux, pneumonia. There is one condition which is associated with the patients with cerebral palsy. That is latex allergy. Okay. It has association with latex allergy.
Okay.
And it is also related to the repeated procedures, as well as these patients are usually sometimes bedridden. Okay. And they have some as I told you that some of the patient, they have bladder dysfunction and recurrent infections, repeated surgeries. Okay. Actually, these are only small number of things which you have to know about cerebral palsy. Rest of the things are the common things which we have already discussed, related to positioning, related to IV lines, related to difficult airway, risk of aspiration. In addition to that, you will have these patients will be at risk of aspiration. These patients will have at risk of fits. Okay. They will be taking some antispasmodics, special medications they are taking. Even some of them are also taking baclofen and benzodiazepines for muscle contractures. Okay. And what are the medications which they are taking for gastroesophageal reflux? Is there any correlation with anesthesia? Yes, Azhar. Any medication you can recall? Actually, for reflux, it is not H2 receptor. It is usually these medications are prokinetic agents. So prokinetic agents, one of the group is metoclopramide. Okay. They have they can cause dystonic reactions. And one of one of the medication which they are says is like has some effect on QT interval. What is that medication?
Sir, cisapride, sir.
Methapride. Okay. So prolonged QT and torsades. Okay. Usually the same challenges which are there in any pediatric patient, you will have the same ankylosis and problems related to IV cannulation. We have already discussed, so nothing special about it. Just few words about.
Sir, do they have a decreased upper airway reflexes? I mean, do they have increased chances of regurgitation?
Bulbar weakness. They have.
Bulbar weakness, yes.
They have involvement of bulb, because actually usually these
Group of people.
this is because I told you that there is spastic lesions or weakness, like there may be plegia or spasticity or dyskinesia, okay, or movement. Like they have variety of syndrome. Mainly it is most common is spastic, okay, but they have weakness as well. If they have weakness, they will have this problem more of reflux because of bulbar weakness. Okay.
Sure.
So because whenever there is chest infection, there will be repeated pulmonary infections and leading to pulmonary hypertension and heart failure. It can occur in any it is chronic. Okay. Similarly, there will be fibrosis may also develop because of chronic aspiration as well. So when they are not taking the food properly, there will be chances of nutritional deficiencies as well. Okay, so they can have they will be dehydrated as well. They will have electrolyte imbalance. Like, you can link your answer and you can think about anything related to it. Okay, so the problem due to its complication, problem related to its medications, problem related to the coexisting problems. Okay, and concerns related to the medication patient is taking. So these were few things which I just wanted to discuss, because we will finish pediatric anesthesia today. Few words about emergence delirium. Okay, so what are the causes which are related to development of emergence delirium? Any comments?
Sir, patients with the hearing aid or ophthalmic eye aids, low.
Your answer is correct. I'm sorry to interrupt you, because of our discussion focusing on pediatrics. Okay, so these concerns which you are telling are related mainly in elderly patients. Okay,
Sir.
so what will be again, as we always discuss, that there are some patient factors, anesthetic factors, and surgical factors. So just imagine which patients will be at risk of emergence delirium. Babies more, like we discussed. If they have some developmental problem, the condition which I told you, ADHD, attention deficit hyperactive disorder, they will be having more chances. Okay, if any other psychological problem, they will have. And what will be the anesthetic factors, like for any patients? What are they?
Of benzodiazepines,
Yes.
prolonged surgery, electrolyte imbalance.
Yes. Anxiolysis and anxiety, preoperative anxiety. Okay, preoperative anxiety. If the baby will be you are not able to give any anxiolysis, and baby is was not comfortable to start with, there will be chances of emergence delirium. Okay, if you keep the baby hypothermic, there will be chances of emergence delirium. Okay. And what like any other anesthetic factor you can recall?
Yes, isoflurane, use of sevoflurane.
Sevoflurane, which volatile is the most related to emergence delirium?
Sir, I guess sevoflurane, especially in pediatric population. So it is
Is it
recommended that
sevoflurane? Is it sevoflurane or desflurane?
Sir, I
I
suppose
think
it's
both.
sevoflurane. Sir.
It is
Yes, I have
sevoflurane.
read about sevoflurane, but I haven't read about this. But I'm sure that sevoflurane causes delirium, so that's why some books recommend that while during extubation you should switch over from sevoflurane to isoflurane to decrease the occurrence of emergence delirium.
Actually, I will just tell you something. That if you are talking purely on practical, that's yes, of course, desflurane is not available in most of the parts of the world. Okay, it is available in lesser uh, percentage of anesthetists as compared to the people who are using it. But desflurane is the nobody is using isoflurane. Okay, in majority of the higher centers, desflurane or sevoflurane is being used. Isoflurane, halothane actually is not available. Okay, like majority of the centers, you will not find isoflurane because there is no need for isoflurane.
Sir,
If you have
In Pakistan, majority of the centers have isoflurane. Desflurane
no,
is
no,
very, very, very rare.
that's why I'm not labeling any specific country. I'm just telling you the percentage of the higher centers. If it is like where there are facilities of international standard, you will not find isoflurane. I'm just telling you. Okay, so if you are answering it, you should have a logic for it. Isoflurane, just tell me one thing. What is the reason for this emergence delirium? Do you know? Is
Sir,
there any
not
specific reason?
specific to emergence delirium, but yes, the pathophysiology of delirium, yes, there might be some, imbalance of the neurotransmitters like phenylalanine or dopamine, tyrosine, acetylcholine.
You are right, but actually there is no specific. Usually, if the patient is awakened quickly, okay, so theoretically, if the patient is awakened rapidly, rapid emergence, will and the baby is still with the unfamiliar faces, yeah, there are more chances of emergence. So in that way, I actually theoretically, because who has the which volatile has the fastest recovery theoretically?
Sir, desflurane.
Desflurane. So I think it should be related more to desflurane, but the data is suggesting something else. Data is suggesting with sevoflurane. Okay. So actually, if you are talking about emergence delirium, both sevoflurane and desflurane are associated with emergence delirium. Okay. And isoflurane or halothane is not the risk is less, but it can happen with isoflurane as well. Okay, so this is so that's why whenever you are telling, you can say that if it is available, you can switch to any other volatile which has less incidence. But actually, with it can happen with anyone. So it is not recommended. Like you use the word recommended. I don't think so. You should be using the word recommended. Okay, there is no recommendation to shift from sevoflurane to isoflurane, because the examiner can catch you. Just tell me one thing: which medication has more chances of airway reflexes?
Chances of airway reflex
Airway
above.
irritation is most airway irritation caused by isoflurane.
Okay, so if you will use this word that I will switch from sevoflurane to isoflurane, any examiner can catch you on this thing. Okay, that you are giving a medication which is irritant. Okay, so the same problems which are there at the this one at
Sir,
induction.
it is not that much irritable when the patient is intubated. It is for induction it is irritable, but once the tube is inside, it doesn't cause
No,
any
no,
irritation.
we are talking about extubation now. Okay, we are talking about extubation. So I'm just telling you that actually there is no, I'm just pointing it out that if you are using a closed-ended sentence, then you are caught. Okay. So you will say that it is associated with use of volatile anesthetics. It is more with sevoflurane. If you use certain, it's in some time examiners are like they are not able to accept your answer and they will catch you and then you will be stuck. So that's why I'm telling you that try to use diplomatic word when you are appearing in the oral part. Okay. If you are having an MCQ, if you have all the volatile written, you will pick sevoflurane. If you are comparing with any other anesthetic agent, then volatile, then you will pick volatile. Okay. So that's what I wanted to tell you. Okay. So perioperative pain, acute pain is one of the biggest factors for emergence delirium. Okay. Emergence delirium. Okay. And you will be surprised that usually we say that ketamine is associated with emergence delirium. But actually, in some data, you will see that use of ketamine will decrease in an analgesic dose. Actually, you are decreasing the incidence of emergence delirium. Okay. So this is something strange for majority of the people who are using ketamine. Am I right? Because ketamine is a wonderful medication. Believe me, if you ask one anesthetic agent which you use it with care, it is a wonderful medication. That is ketamine. Okay. Even if you are, I can guarantee you, if your patient is in pain and you are giving it in a very low dose, actually the heart rate will not increase, rather it will decrease. If you are treating the pain, of course, you cannot quote these words in the exam. Okay. Because in majority of the books, it will be written that ketamine is, I will tell you that at the same time, what's effect of ketamine on pulmonary vascular resistance?
Bronchodilator, sir.
No, we are
Sir,
talking about.
it increases the pulmonary hypertension it causes.
Okay, just tell me one thing. What is the more trigger of pulmonary hypertension? Stress or
Hypoxia.
ketamine? Huh?
Hypoxia or stress, sir?
So if you are
It's hypoxia.
decreasing, if you are covering the pain in a better way by giving a very low dose of ketamine, should it reduce the stress or increase the stress?
Decrease.
Okay. So actually that's what this is unfortunate that sometimes we create a hype of a lot of things. Of course, you cannot quote it in the exam. I again repeat, because in the exam you have to follow the books.
We have
But I'm
other
telling
better
you,
options also, sir.
like,
We have other better options. Like, why are we so much in like, why are you using ketamine for analgesia? We have other options also.
have you done pediatric cardiac
That's
anesthesia?
pediatric cardiac, no, sir.
Okay, so I will tell you, even I was surprised to see that in pediatric cardiac anesthesia, where there is no patient without right to left shunt, okay, without pulmonary hypertension. If you find a patient with pediatric cardiology problem, okay, but in 2 years of my stay at one of the topmost cardiac center in Saudi Arabia, my concept was totally changed. And then I came to know that if you are using ketamine in a proper way, ketamine is not causing anything bad. Rather, it is giving good in a more appropriate way rather than any bad. Okay. So ketamine is the sum of the side effects which are there related to its hallucination. There will be research and they will be removing that effect. So ketamine is a medication. If you are using it in a smaller dose, it has no problem. Okay, it maintains SVR more than If you are, for example, Usman, if you are using this one, what else you will use? You will use propofol, okay? You will use any other medication. It will have more cardiac depressing effect, okay? And it will have more effect on SVR. So what will happen? If SVR is decreased, what will happen? Yes, Usman?
In pediatric population, sir?
Yes.
Sir, definitely if SVR is
Not, I'm not talking
decreasing,
about,
then
no, Usman, I'm not talking about pediatric population. I'm talking about patients with right to left shunt, okay? The patient with right to left shunt, your aim is to maintain the SVR, am I right?
yes, in that case, definitely, sir, in right to left shunt, we maintain the SVR. We also give
Yes.
phenylephrine, especially in the patient of
Yes.
TOF or
So that's what I'm trying to say,
yes,
that
in that
actually,
case, definitely, sir. In that case, definitely.
yes.
I also use ketamine in that particular patient with phenylephrine in my hand, definitely.
Yes. Okay. So no, because ketamine will not have any effect on SVR. Okay. Rather, theoretically, if you read the books, they will say that ketamine increases SVR. Okay. That's why you are not using ketamine actually. You are saying that ketamine is increasing the stress on heart. It is causing tachycardia. It is increasing blood pressure. But I tell you that if you use it in a very small dose, it has too good effect. Okay. So I will as a practical conduct of anesthesia, I will suggest you to use it. Okay. Okay. So any other question, because we discussed a number of things now. Any comments or any topic you want to discuss? I want to show some of the things related to. Yes, Azhar, any comment, anything you want to say, please?
Yes, sir. First of all, that inhalation and induction is that in relation to delirium we discussed earlier, that it's the same questions comes in the MCQs, and both the options are there, like the sevoflurane and desflurane. What I should reply?
Sevoflurane.
Okay.
Okay, but I'm just telling you that practically they are actually, there will be so many, it will not be a single word answer actually, but because all anesthetic agents are doing it. Okay, but if it is coming that all other anesthetic agents are written, and you are talking about this one.
So I don't think so. They'll give two options, desflurane and sevoflurane.
Yes,
Yes, probably hypothetically speaking, actually both were options were discussed, so
No,
that came in.
such MCQs doesn't come. They have a very, they first of all they'll give you a scenario, and the answer would be not like take the sevoflurane or desflurane.
Can you please mute the mic, please, every one of you? Okay. Actually, there is a possibility of every question. Okay. Usually, actually making MCQ is more difficult than anything else. Okay. So that's why.
Yes, sir, straight away MCQ doesn't come which of the following agent cause emergence delirium, and the options would be sevoflurane or desflurane. These type
No,
of
there is
MCQs now.
possibility. Usman, there can be. They can give you a scenario, and then they can ask you in a different way. Okay, because as actually if you discuss about the quality of the MCQs, it should not come. Okay, but actually such questions are there in the pool, and they may be asked. So if you have to choose, the most culprit one is sevoflurane. Okay, this is what Azhar wanted to say. Okay, we have discussed these things. We will just I will just show you this book I just found today. and actually this it is a very good source for revision. We discuss about airway obstruction, okay, and the possible causes. We discuss about infective versus non-infective, okay. The people who have attended it know, they can review it, okay. And airway obstruction, how the second thing will be, which will be important, will be how to assess the severity of airway obstruction. Yes, Jamil, would you like to say something?
Yes, sir. Yes, actually, sir, where I am sitting, there is very bad connection, and I could not properly listen. Your voice is distorted. Can you repeat the question, please?
My question was, how will you assess the severity of airway obstruction?
Severity of airway obstruction. Yes, sir. It's sir. Depends upon means airway obstruction. Your treatment perioperatively means in the after extubation or in recovery, or just air assessment in the emergency.
Like airway obstruction can be in usually upper airway. If you are talking about airway obstruction, you have to first of all differentiate whether it is upper airway obstruction or lower airway obstruction, okay. But the usual signs symptoms will be respiratory, from where you start, respiratory rate, respiratory pattern.
Actually, sir, if we generally talking about the patient presents in the emergency, like we don't know what is the real reason. Maybe foreign body will be acute epiglottitis, or just first
We are
of
not
all
talking about Jamil, we are not talking about cause. We are talking about the signs, or how will you assess the severity of airway obstruction, okay. So actually this is
first of all on I think on on inspection, the patient most probably will be in sitting position or pediatric patient, and he will be prone to forward with the he will be tachypnic with nasal what do you say, the nostril what is the proper word for
Nasal flaring.
flaring? Yes, nasal flaring, and with respiratory distress, he will breathe with the help of extra respiratory muscles, means scalene muscles, and external costal muscle or abdominal muscles. Their signs maybe might be drooling due to the upper airway obstruction, severely obstruction, and he will be
yes,
anxious.
if you even summarize it,
And
rate,
by look,
pattern, rate, respiratory pattern, any signs of like fatigued
Sir,
breathing,
Strider, the
or
most important one is.
stridor, cyanosis, wheezing, okay, and any other cardiovascular sequelae, sweating, okay. And so like it will be that in that way you will be able to identify whether it is upper airway or lower airway obstruction, and then you will label it as severe or mild or moderate, okay. And then of course there will be some signs for infective, some sign for non-infective, some signs for upper airway, some sign for lower airway in the form of stridor or wheezing or anything else. Then you will be, your approach will be generalized.
reasoning or crackles.
Yes, then you will
Hoarseness
be
of the
approaching
voice also.
hoarseness of the voice also. Yes, okay. And then you will be tracking it with the history examination, and then you can use, if the time is permit, if the situation is permitting, you can have some radiological study if you are suspecting foreign body, but you will not be delaying.
If patient is stable,
Yes, okay. And then you will be using some antibiotics, you will be using some steroids, you will be using racemic epinephrine, you will be targeting if it is suspect, because foreign body can be delayed, can be early, Even there will be a foreign body in the lungs, and maybe it is presented as a pneumonia. Okay, so there will be a lot of variety uh, in the picture. So the basic approach will be in like that. So like you, this is the same thing which we discussed, that steroids and
Yes, like
nebulized.
peanut or anything else, yeah, sunflower seed.
Yes. Okay. So this is usually you will not attempt to intubate unless you have all the facility to deal with the possible sequelae, like getting ready for tracheostomy,
Cannot run
or
into bed, cannot ventilate scenario, yes.
yes, cannot intubate, and because at any time, if you are suspecting, for example, foreign body, or if you are suspecting even any infective cause, the edema can suddenly increase, and you may have not able to ventilate even. Okay, so this is an
You
important
properly
question.
then are intubate the patient.
Yes, emergence delirium, as we discussed, pain, hypoxia, hypoglycemia, these are the risk factors as we discussed. Residual anesthetic, hunger, thirst, hypothermia, sepsis. Okay, this is more we see it in adults. Okay, but it can occur in pediatric like that as well. Okay. You will be checking the blood glucose level, APGs, and you will be treating the pain. You will give some anxiolysis, and then you will be escalating the things. Okay, emergence really a collection of symptoms that may be displayed in children in the immediate post-operative period. Okay, and patient factor, preschool
Yes,
age.
sir. Actually, maybe if it is not distracted, we can discuss about the postoperative acute pain assessment in pediatric patient. If
Jamil,
it's not
actually,
proper the
pain,
topic.
pain we will discuss separately. Okay,
Okay, okay, sure.
pain we will discuss separately. Okay. So these are the factors. Yes, Arsalan, would you like to say something?
Yes, sir. I have a little bit confusion between tracheostomy and cricothyroidectomy. So I don't understand which procedure we have to prefer in children. Just
I think it is
hello,
tracheostomy.
sir. Yes, sir.
Yes. Any comments, please, Jamil? I think it is tracheostomy. Am I right?
I could not again, actually, sir, I am
He
out
he's
of my
he's
home.
saying
And
he's saying that what will be the difference between tracheostomy and cricothyrotomy in pediatric patients? Okay, like if you have to do the emergency airway management, whether you are going for cricothyrotomy or tracheostomy.
yeah, tracheostomy is preferable, Yeah. Tracheostomy preferably because there is very small, first of them, the membrane, cricothyroid membrane, and you cannot find in pediatric patient in situation in emergency situations. And already the trachea is very small, and further you have no time, to find all the
How
membrane. And
long, excuse me,
sorry.
how long it takes tracheostomy for a pediatric? How much time? Do you have still time to perform tracheostomy if the patient is having severe airway obstruction or emergency airway obstruction? I'm much confused because I have seen a patient in which I inserted it was I think a baby of 2 to 3 months, and it was foreign. It was basically foreign body right in front of a trachea. And I had to pass a IV cannula of I think 18 gauge, and it worked a lot. I didn't have any time for tracheostomy.
No, no. Listen.
No, you can.
I tell you
Yeah.
something. Just a second. Let me answer. Usman, your answer, your concern is absolutely valid. The thing is that you are doing cricothyrotomy preferably in case of emergency. Okay. So cricothyrotomy is a rescue procedure as you did in your patient. Okay. So cricothyrotomy is an emergency procedure, rescue procedure, as you did in your patient. Similarly, tracheostomy, you will need more specialized people who, not everyone can do tracheostomy. Cricothyrotomy is actually with the way which you did. Are you around or he's left? Usman, I think he
Yes.
has left. Yes, I
Yes,
cannot
yes,
see
sir.
you. I cannot see. Yes. So I hope you understand the point.
Yes, sir. I thought they were talking about an emergency. Definitely, if the patient is not in emergency, then there would be a definitive airway, and that is tracheostomy. That is not cricothyroidotomy.
Yes. So actually, there is a gray area in the in this answer. Whenever you are dealing with anticipated difficult airway, okay, you have to prepare yourself for tracheostomy. Similarly, if you have a patient with this epiglottitis or crew, or you have foreign body, you should be prepared. You should have to, at least you should be thinking in your mind about tracheostomy, about cricothyrotomy, about fiber, this one, rigid bronchoscope. Okay. So this is what I wanted to tell you. So as we discussed, desflurane and sevoflurane, both of them are residing here. There are some patient factors, some surgical factors, especially I forgot to miss it, ENT surgery, because the nose will be blocked, and it is one of the biggest factor. I will be very happy if you people mute yourself. Everyone got disturbed with it, and please take care of it. Okay. So this is the topic which we discussed today. How to deal with it. You will be doing the same approach, airway breathing circulation approach. You will be checking the blood sugar, and you will be approaching accordingly. Okay. You see, this is right here, ketamine. Ketamine is everywhere, wherever you go. Okay. So and enzylysis at the preoperative time is the key to avoid uh, emergence delirium. Okay. So I'm just passing through quickly. Neonatal emergency surgery. You see that I will just, what are the neonatal emergency surgeries? If you can just think, can be obstructed hernia. Okay. There can be foreign body. There can be infective, the intestinal obstruction, laparotomy. Okay. What else?
Sir, diaphragmatic hernia.
Diaphragmatic hernia usually is done after optimization. So it is not emergency surgery. It is never an emergency. It is not a
The
surgical
biliary
emergency.
atresia,
Huh?
caloric stenosis.
You see, now you can see perforation. Okay. Obstructed hernia. Okay. They are doing these usually are emergency abdominal surgeries, uh, like intestinal obstruction because of volvulus. Just pardon me for a second. I just have to receive a call. Just give me a second. You can speak out for a few minutes. Yes, please. So whenever you have an emergency surgery, okay, so you will have these concerns, like any patient. If it is a neonate, you have to chalk out the post gestational age. Okay. And in addition to the birth history, this is extra to what you do for any other patient. Okay. And rest of the things actually we have discussed in detail. uh, Okay, so I will just try to wrap up. I just wanted to show you this. This is actually a new book. I just got it today, and I shared with in all the groups. Okay, so we will start elderly anesthesia. And as Jamil mentioned about pain assessment in pediatric, yes, you're right. We can do it, but I think I was thinking to do it with the pain. With the pain, we will do pain shortly. Okay. So thank you very much for your presence, and you can see any question related to pediatric anesthesia. You all are welcome. If you are shy to ask at the moment, you can ask anytime. Okay, and then I can answer to you. Yes, Arsalan.
Sir, one question asked me from my supervisor that at which level of creatinine we prescribe dialysis. So I don't get the exact value. Can you please help me?
Is it only the creatinine value for which you do the dialysis?
Yeah, yes, sir. It is exactly the word which he said to me.
No, I don't agree to him. Any comments for it? I don't agree to the question. Any comments from all of you?
Actually, yeah, there is no upper limit of any creatinine level. Depends upon the how it's rapidly raised or
And
it's
what is the
symptomatic.
situation? Overall
Yeah,
picture.
what is the situation? Yeah. Sometimes it's increase in case of rhabdomyolysis, and there will definitely they go early. With depends upon the potassium level, depends upon the other clinical features. Then they rapidly go to the dialysis because there is good prognosis. But in chronic renal failure, they will not go at there are different definitely the labs and their parameters of for creatinine, but unless they manage the patient is not symptomatic, not fluid overload or not severe acidosis, and they try to manage
And the
conservatively.
GFR, I think GFR is more appropriate way to for the dialysis, not creatinine. If the GFR
Yes,
is less than, I think.
GFR,
Yeah.
GFR,
Yes.
Usman, I will add on to your answer. It is GFR. It is a condition,
Yes.
and that's for that thing. The rifles criteria is there. Okay, like rifle criteria or the overall condition of the patient. Maybe you are doing dialysis even at a lower creatinine level. If you have a risk factor like that, am I right? So
Sir,
creatinine
it
is yes.
So it's mean we have a patient and he's vitally stable. Whatever its creatinine level is, we can under the patient. Oh, this is what you are saying.
No, it's listen. What are the indications for dialysis? When dialysis is being indicated, is it the creatinine level which leads to a patient for dialysis in a CRF patient? No. Okay. There will be reduction in as Usman told. It is the relation to the GFR. It is relating to any serious complication which occurs, like any hyperkalemia.
We
Okay.
also see potassium, we see pH, we see fluid overload, we see NCAF, so many things we see.
Yes. Yes. Okay. So like this is I think he has to revisit the question which he asked to you. Okay. Any other question? Okay. So thanks a lot everyone for your presence, and we will start next time inshallah elderly. Okay. Thank you very much.